All right, welcome to the Resolution Room, Dr Lovell and Vanessa Daniel.
Thank you. Thanks for having us, Damien.
No problem at all. I'm really proud of my collaboration with MLCOA, the Law, Medicine and Everything in Between series. It's pretty much covered law and medicine, not everything in between, but we might get to that. But let me do an intro if I can. Thank you for your time and your expertise, Doctor. I mean, psychiatric injuries are really important now, increasingly important. We're seeing pressure put on all schemes of insurance with psychological injury claims. So it's an opportune time for us to talk about this issue. We're going to drill down into PTSD, but let me give you, as best I can, a background of your long and varied career story. What makes you interesting is, of course, your emphasis on forensic psychiatry. You're a fellow of the College of both Australia and New Zealand. You've been working as a forensic psychiatrist for many years. You worked as a consultant at Queensland Health till about circa 2012 or thereabouts. And of course, for our purposes, what makes you fascinating is you were a co-author of the PIRS, which is used commonly now in the assessment of psychiatric impairment. I'm sure if I missed something, Dr. Lovell, in your career, or is that a good summary of your background?
That's a good summary. I like to jump ship every 7 years and get something that's a little bit more stimulating and interesting.
Excellent. Well, we're going to come to psychiatric injury because you gave me a sneak peek of a presentation you did, and it really drew down on the history, which I think is fascinating because it's a relatively recent phenomena in the grand scheme of psychiatric conditions. But Vanessa, over to you.
Thanks, Damien. I'm the National Legal Manager for MLCOA, and I manage the concierge team. And that's just a process to help referrers simplify medico-legal reports and requests just by getting the request to come into us and seeing what your needs are, how we can best align specialists to the conditions that your claim might have, and just like an end-to-end process.
Excellent. Bridging the gap between, I guess, clinical expertise and the evidence side for lawyers and your stakeholders.
Yeah, definitely. Just make it a bit easier for everyone and using empathy as well along
Excellent.
the way.
I'm really proud of this collaboration. MLCOA is the largest medico-legal provider, 400 specialists on your books. Dr. Lovell is one of them, of course, and has worked extensively with you guys. He's just come out of a morning full with medico-legal assessments as we speak. Okay, PTSD, the good doctor, PTSD. Now, let's paint the picture historically. Trauma was considered just a part of the human condition, was it not? And only in more recent times has it been considered that it could give rise to psychological symptoms. Is that a fair statement to begin with?
Yes, it is. It's always been there, but as we've become more aware of things psychological, it's taken a greater position in terms of the forefront.
Before we used it as a term, and I think it came in, correct me if I'm wrong, in DSM-3 in 1980, it was formally recognised a condition, is that right?
They amalgamated two things, the rape trauma syndrome and the post-Vietnam syndrome.
Right.
They put them together and it appeared as post-traumatic stress in the anxiety chapters of DSM-3.
But we've always had some understanding of the human capacity to ruminate or to replay or have intrusive memories. I mean, this goes back before Vietnam, doesn't it, in terms of, talk us through railway spine and shell shock.
Okay, well, look, the British are big on their trains. They introduced the train system to India. And in the 1840s, what happened was that 250 million Brits started travelling by train. And the trains weren't all that good in those days, and there were a number of train accidents. And one of the victims of these train accidents happened to be Charles Dickens, the author. And he described beautifully some of the symptoms of what is now PTSD. He said, "I find it inexpressibly distressing that I get the feeling that the train carriage is tipping on one side." And then subsequently, he stopped travelling by train. So what he's really describing are flashbacks, a dissociative phenomena, and avoidance, which are two of the 4 groups of PTSD symptoms.
Charles Dickens, what a great example. And of course, then there was reference was it World War I, the reference to being shell-shocked? What were doctors describing? Were they considering it more of a neurological problem or a psychiatric problem? Or
they thought that the brain was shaken in the skull. And they described things like neurasthenia, which is neurological weakness, but they also describe things like re-experiencing and fugue, people not knowing where they were after a near-death experience, after a mortar landed beside them. And there was a huge debate at that time about whether they were bunging it on as to get away from being killed.
Yeah, it was a pretty horrific war, of course, as you know, all wars are, but there was something very brutal about running over hills with bayonets. So why did it land then initially in DSM-3 in 1980, and what role did Vietnam and the veteran experience play in that?
The Vietnam War was different. There were napalm bombs, there was Agent Orange, you didn't know who the enemy was. Instead of coming back as heroes after war, they were sort of spat upon as child killers, and there was no gratitude for what they had done. And they'd been in awful circumstances, and the veterans began to drink, drug, because there was a greater availability of substances in Vietnam, and they had a lot of difficulty processing and reintegrating after the war experiences.
I'm fascinated by the history of PTSD, particularly its relatively recent phenomena. Vanessa, it's landed now in DSM-5. Is it classified as a trauma-related condition in the DSM-5 now?
Yes, it is. And it was moved to the trauma chapter because it was more than intense fear and anxiety.
Right.
There were a lot of behavioural concomitants. There were a lot of other issues and emotions such as guilt and shame. And there was a clear precipitant, whereas most anxiety disorders don't have a clear precipitant. They're constitutional and lifelong.
Okay. Talk us through now, Doctor, what are the qualifying criteria and where's the debate generally?
A lot of the debate is about whether or not it's a Category A stressor. A Category A stressor is something which would overwhelm most people's coping abilities, and it basically refers to near death, seeing somebody die, being sexually assaulted, being in a car accident and thinking that you're going to die because the car's caught fire and you're going to be burnt to death. Things that generally are outside the realm of normal human experience. It also includes things like natural disasters, earthquakes, 9/11, all sorts of things like that. So really, before we can even look at making the diagnosis, we've got to have that Category A stressor. Lots of people in minor road traffic accidents think that they might die, even though they're hit from the rear at 30 kilometres per hour. It's a frightening experience. These people have had a fright, not a Category A stressor. They're not trapped in the car. A lot of people misinterpret the airbags going off if they're pushed into the vehicle in front to smoke. And these are perceptions rather than reality. Frequently, if people are prone to post-traumatic stress disorder and they're anxious souls, they will experience some dreams, some dissociative flashbacks, and they will avoid travelling by car. But these people don't have PTSD. They have an admixture of anxiety, depression, and a travel phobia, and they would be best described as having an adjustment disorder.
Okay, and generally it flows from that the usual, if you like, debate is between that you may have internally is, does this classify itself as A, an adjustment disorder, or B, potentially a PTSD?
Exactly.
Right.
In many ways, there isn't a lot of difference in terms of treatment, but there is a lot of difference in terms of what happens in the longer term. People generally recover quite well from an adjustment disorder when the stressor is taken away. The prognosis is poorer if they have post-traumatic stress disorder for longer than 6 months.
If an adjustment order isn't treated or they don't get diagnosed, does it progress to PTSD, or what's the time frame? Or
Well, no, it doesn't. What happens initially is there's a category in the DSM that's called acute stress disorder, and people have the same symptoms of PTSD, but it gradually resolves over about a month. And I mean, people are generally quite resilient.
Yeah.
And with psychiatric first aid, empathy, linking them up with support organisations, early interventions, most of these acute stress disorders will in fact settle. And if you look at, say, 9/11, the figures are that only 0.6% of people at 12 months had enough symptoms to qualify for PTSD.
Yeah, and they would have been exposed to a lot of threats.
A lot
and,
of trauma.
yeah,
Very much a category A.
long-living Yeah, yeah,
It's a
very
category A
much.
stressor,
Absolutely.
but people sort of hung together. There was an awful lot of support.
Yeah.
A community support. Yeah.
Even at a global level. So we've talked about a category A stressor, and you obviously at times would disagree with a psychiatrist who've classified something in your reports, and you would say you don't think it qualifies as a category A stressor. What are the other symptom patterns that you need to make the diagnosis?
The first thing you need really are intrusive symptoms, and these are the nightmares of the event, the dissociative flashbacks, memories which are unwanted, which come into consciousness. These are often associated with symbolic triggers. I mean, if someone's trapped in a car that's on fire, smell is something which will trigger the symptoms, and they will go back to the original accident. So we need those. And then the next thing we need is avoidance. I mean, one of the things, if you burn yourself on the stove, you're very wary and cautious, and you avoid going back to where you hurt yourself. And similarly, people avoid the accident scene. They avoid the workplace where they might have been sexually assaulted.
Yep.
And that is quite problematic. They tend to generalise their condition, and they look for triggers, and that causes increasingly avoidance, particularly with the police, who, when they are diagnosed with PTSD, begin to remember a lot of earlier trauma, and they end up often housebound because there have been so many events that have been traumatic in different places that they begin to avoid.
That's fascinating. So we talked about, to summarise, you've got obviously the category A stressor, you've got avoidance, and you've got the rumination aspect, or the what would you call the second category? The
intrusive
yeah. Sorry, I called it
symptoms.
intrusive symptoms, a flashback type. And that's what probably people are talking about with shell shock, people or Vietnam, people getting dreams and rumination.
And of the threat too, wouldn't it be to seeing the threat of death and
yeah, that's the next one, Vanessa. You're always one step ahead of me. The next one are the negative thought patterns, like the world is a dangerous place. If I go out again in my car, maybe somebody else is going to run into me. People generally tend to lose interest in their activities, and they tend to be quite numb and detached. And they're very common symptoms.
And so once you have this category A stressor with a combination of that symptom pattern, you're satisfied from a forensic perspective.
Although, no, wait, there's more.
Wait, there's more. I go too soon.
Like a free set of steak knives.
What else do you need?
Okay, we want marked arousal. Okay, that's why it was in the anxiety chapter previously. I mean, people are vigilant, watchful.
Yeah.
Often the veterans will say, I go into a crowded restaurant and I sit with my back to the wall because I want to watch everything that's happening. And they've got an exaggerated startle.
Yeah.
Vanessa doesn't. Okay? And obviously when people are anxious and vigilant, their concentration's poor, they have difficulty with sleep, and then we get into all sorts of other difficulties in terms of substance use and alcohol. But before we can make the diagnosis, even if we've got all of these, there has to be significant interference with social or occupational functioning.
Right.
If they continue to function at work and if they continue their social activities and hobbies, even with this constellation, they still don't meet the criteria for PTSD.
I hear you, because effectively they might otherwise have a distressing condition, and it might be very distressing, or a stress reaction, if I could call it that, but their functioning in itself at that level of work and hobbies would suggest it's not an intractable PTSD diagnosis.
Exactly. And I mean, it's interesting when you look at some of the long-term studies like George Vallant from World War II veterans. People never forget their war experiences. They continue to dream about them from time to time. But their level of functioning, if you look at them with matched controls, is often better than a general group in the general population.
Right. That's fascinating. It's quite a list, isn't it? You would think, based on that criteria, a relatively rare diagnosis, particularly when you look at, say, 9/11 is a good case study. What does the numbers tell you about Vietnam? Is there any studies done of how many veterans had the condition post-Vietnam?
Yes, we can look at the long-term studies in Vietnam easily. Best one is one of a 30-year follow-up of 450 vets. Just by background, 50,000 served in Vietnam. 500 Australians were killed, 2,500 were wounded. If we look at these 450 vets, 30 years on, 28% are on antidepressants, 19% are on sleeping meds, 16% are on anxiolytics, and 60% are drinking.
Right.
So they didn't do very well.
No. And that tendency to use alcohol or substance, is that a self-medication response?
Well, you can't sleep.
Yeah.
You might have a drink to go to sleep. Or if you're experiencing flashbacks, it's better to sort of dumb them down and not be quite as conscious. Alcohol is quite good as an anxiolytic.
Yeah.
I mean, if you want to ask somebody out, have a couple of drinks before you make the proposal and make the date. But at the same time, as you drink more, it's actually a central nervous system depressant. And these guys get into trouble with major depression because of their alcohol use and also because of the restricted patterns of behaviour and the general difficulties that they have in forming social relationships.
Well, I thought that was interesting. Vanessa, do you think you get a good snapshot of what the condition is now in terms of the diagnostic criteria?
I think so. It helps us identify some of the axes of diagnosis and stuff a bit clearer. Yeah.
I thought we'd take a bit of a pivot now and talk about the mystery of resilience. We're going to talk with Charlotte Campbell, who's coming on next, about the law of causation and eggshell skull. And you've been legal adjacent for many years now as a forensic psychiatrist. And of course, I often marvel at that reality that two people can have response to the same stressor, but one really does decompensate and one doesn't. So what are some predisposing factors or vulnerabilities that surface and that you see commonly in your forensic practice, Doctor?
Number one has got to be access to personality. People who are obsessional, like you, Damien, when they're exposed to an unpredictable, unexpected, traumatic event and lose control, are more prone to PTSD.
You summed me up well in only 20 minutes.
Yeah,
incidentally.
I know.
I'd hate to spend too much time in your rooms, but so in other words, so there is a predisposition for an obsessional, perfectionist.
Yep.
Rigid. Is that follows as well? So a rigid sort of more rigid.
Obsessionals always tend to ruminate. I've had the accident. What else could I have done if I'd left 15 minutes earlier? If I'd taken another route?
Yeah.
If I'd done this, well, then this wouldn't have happened.
Yeah.
And then there's the sense of justice. They ruminate about the trial of the driver at fault if their son's been killed, and these ruminations often lead to restrictions socially. They stop doing all the things that they liked to do previously.
They withdraw.
When you don't do pleasurable events and engage in hobbies, well, you get depressed, unfortunately. The other group are the narcissists,
Right.
the people who think they are invulnerable, that nothing can touch them. And when they have an accident, and particularly if they're disfigured, because appearances are very
Oh, of
important,
course. Right.
okay, they don't do very well. They decompensate into lots of anger and tend, as most personality disorders do, to project their difficulties onto other people, and they want vengeance, they want settlement, and they want justice. That's personality. The other things that are very important are previous trauma, in particular childhood sexual abuse. And I mean, sadly, in this country, 1 in 3 girls and 1 in 5 boys under the age of 16 are sexually abused. And that is a dreadful thing, but it actually leads to a tendency to dissociate. When you're a kid, when you're being sexually abused, you tend to go somewhere else in your head, and that's dissociation. And dissociation is the key mechanism of flashbacks, and these people are very prone to develop PTSD when there's a serious trauma later on. Obviously, things like psychological mindedness, IQ, education, all play a part. People who are more educated can use cognition to try and make sense of things and deal with the automatic emotional response. Self-talk is the sort of cornerstone of a lot of the therapies that are provided. And sorry, Vanessa, women are more prone than men.
And before, Dr. Lovell, you were saying it takes about 7 or 8 years for recovery from PTSD.
Whoa, that's
Yeah.
a tough one.
Yeah, that's a
Looking-
good
To put
question.
some,
A lot of people don't get it. That's the first thing. And psychiatric first aid, all the things that happen when someone's been traumatised, early intervention, sympathetic employer who rings up, early debriefing, they all help in terms of stopping the symptoms and preventing them from becoming chronic. If they've still got symptoms at 6 months, then you've got a little bit of an uphill battle. And that's when you start treatments
therapy.
with more aggressive manner. If we look at what happens, there's a rule of thirds. A third will get better. A third may have episodic periods, and a third will remain partially disabled with alcohol, depression, substance abuse.
Talk about that third that gets better. What is the key factors?
Early intervention.
Yeah.
The effective treatments are trauma-based CBT.
Yep. Cognitive behavior therapy.
Yeah. Eye movement desensitization reprocessing.
Yeah.
Just talk about that very briefly.
Yeah.
Francine Shapiro discovered in 1989 that if you have saccadic movements of your eyes from side to side while you had a visual image, we had much the same effect as rapid eye movement sleep. And this enabled people who had intrusive memories to somehow process these, and the results were quite good. Then we've got other things coming into play. There's a role for medication, and the alpha-adrenergic blockers like prazosin stop you dreaming. And if you stop dreaming and having nightmares and you get a decent sleep, you feel a lot better. And there's a role for several of the antidepressants. The ones that people say are effective are sertraline, paroxetine, venlafaxine, and more recently, mirtazapine. Mirtazapine because it's got a fairly strong sedative effect.
What about the impact that resolution of a claim or litigation? Do we know that helps, or is it really just immaterial, really, to the rule of the thirds?
Well, closure is important. Okay, I mean sometimes resolution is often brought about by the person at fault being punished. I mean, I saw a woman yesterday whose daughter was killed in a police chase. The driver was under the effects of amphetamines. He was sentenced to 7 years. Her daughter was 18 years and 6 months of age, and that's what she wanted as his sentence. And she remains bitter and angry at the legal system, and no amount of money is going to take that away. A lot also depends on how long the claim has been going on for, because people fall into certain habits. I mean, if after a road traffic accident you wear a neck brace for 2 years and then you take it off, you've really got problems. And similarly, the behavioural patterns that evolve and the avoidance become chronic.
Become wired in effectively at some level.
Yeah, exactly.
And that goes on beyond after the claim's finished as well too.
Yeah, I mean, a lot of the research on workers' comp claims in the United States find that symptoms aren't alleviated when a payment is made.
Yeah, it's interesting. And I have the conversation with plaintiffs that unfortunately this is a very blunt system, personal injury litigation. It's about money and it's often that's welcome. Sometimes it's not, but it's an important conversation to have. But those numbers of 1/3 having a level of success is interesting. And when you talked about education, is that potentially also a story about access to resources to get the help that you need early, do you think?
Yeah, and it's about understanding the sort of psychoeducation that's provided, making sense of the whole thing, instead of just having an emotional response and not being able to process it at a cognitive level. People who are more educated tend to look at their behaviour, keep a diary, look at negative automatic thoughts, follow the advice that the psychologist gives them, and they're more likely to engage. People who aren't well educated, I'm sort of sounding a bit sort of anti-woke at the moment, tend to think, bloody psychiatrists, they're no good to anybody. I'm going to solve my own problems, and it's no use talking about it. It just upsets me. So I'm just going to try and get on with my life. But it doesn't work.
Well, sadly, we're out of time, Vanessa. That was a great conversation.
Quickly.
Yeah, it goes so quickly. Anything else you should add from the perspective of MLCOA? Well, we've got Dr. Lovell.
Well, when we have people come to MLCOA and they need a bit of extra support, possibly when they've got a psych claim, they can come in with a support person. Yes. Yeah. And then they can also come in with a support animal and stuff, because it is quite traumatizing. I guess coming back to MLCOA or going back to tell your story again can bring up lots of things, I think, for people. So, there's a way around it, and support is available. You just need to let us know, and we can see if we
I
can
get terrified
accommodate
by
it.
some of these big support
Yeah,
dogs.
they're support dogs.
Because as
yeah.
people begin to sort of tell their story and get upset, the large hound starts drooling and puts its paws on your desk, and you worry that it's going to lunge and get your throat because you're the one that's upsetting them.
Yeah. Well, that's actually a great segue, Vanessa, into with Charlotte Campbell, who's a barrister. We're going to be talking about a trauma-informed process, what that is and what that isn't, and how you deal with people, particularly the avoidance aspect that we covered off with, which is important for lawyers to navigate, I guess you can say. So we're going to cover off that. We're going to revisit a bit of the law of causation and vulnerability aspects, and the law can be a blunt instrument, how the law marries all that up. Dr. Lovell, that was amazing. Thank you so much. I've read many of your reports over the years.
Thank you for having me.
So I really appreciate your time and expertise. It's such an important topic. MLCOA, Vanessa, thanks for your support.
It's my pleasure. Thank
the
you.
collaboration with the podcast is excellent. Until next time, thanks again.
Yeah, thank you.
Thank you.